Hi guys, sorry for a little bit of messing around here. I guess I don't have things set up correctly, but anyway, hopefully you can see this screenshot. Anyway, I hope you're all well. We are starting things off in intro to pharmacokinetics and pharmacodynamics. I'm hoping this will be your very favorite class, and I think it's fascinating, and we can do a lot of good to help patients have the best experience that they can with their drugs if we utilize these concepts that you're going to be learning this semester. So we're going to be starting out with an introduction to dosing regimen design. What's a dosing regimen? Well, it's how we give the drug. And that's what we're going to be starting out with. But really, what is the name of this class? So you may be wondering, why am I studying pharmacodynamics? So why, though? Why are we studying pharmacokinetics? What is pharmacokinetics? So if you break down the word, you've got pharmaco and kinetics. Pharmaco is drugs, right? The use of drugs, pharmacology, and kinetics is movement. So it's really how the drug moves around in the body, how it goes in and out of tissues, in and out of different compartments in the body. And that's what determines like its effectiveness. It also determines side effects. And of course, as pharmacists, we want to make sure that we have as good a control over that as possible. So we want to make sure that our patient has the right amount of drug in the right place at the right time. So that's what pharmacokinetics helps us. So it uses mathematical models to ensure that we have the right amount of drug in the patient, in that particular patient, in the right time, in the right place. So I often think of when a person takes a drug, what they always think of is that effect that it's going to have on the body, right? That's why you take the drug. But we don't think about the fact that the body has an effect on the drug. And of course, that's really kind of what kinetics is. The body is affecting the drug. It affects where it can go, where it can't go, how quickly it's removed from the body, etc. So we're going to be studying this. Why pharmacokinetics? Because we want to make sure that our patients get the best quality of care. So using what we know about the drug and the patient, both things, the drug and the patient, we can make our best attempt at ensuring that a patient's regimen is effective but not toxic for an individual patient. So that's really what what our goal is in using pharmacokinetics. So this is what dosing regimen design is, and you can't really see that there, but this is what dosing regimen design is, to make sure that each individual patient with each individual drug is effective and not toxic. So for each drug, we don't always know this, but commonly we'll know what the least effective concentration of the drug is, and this is in milligrams per milliliter. So in this case, our least effective concentration is 20 milligrams per liter, and our top effective but not toxic concentration is 50 milligrams per liter. So ideally, we never want to go below 20 milligrams per liter, and we don't want to go above 50. Here's where we start seeing toxicity. Here's where we start seeing lack of efficacy. So when we give a drug, it doesn't just stay the same concentration, does it? We give the drug and the concentration goes up, and then the concentration falls. So we ideally want, within a dosing regimen, we want that drug concentration curve. And by the drug concentration curve, what I mean is when you plot concentration versus time, you can see how the concentration increases over time and then falls as the drug is eliminated. So we want to make sure that that's within those two concentrations if possible, or as much as possible. So here's a perfect concentration time curve, because we're starting out here. Here's our initial concentration, and this is at steady state. So the concentration here is just above the minimal effective concentration. It goes up to a maximal concentration, which stays below that minimum toxic concentration, where we start seeing side effects. and then falls down. And before it falls below our minimum effective, we're going to give it again here. We're going to have that same curve at steady state. Each of the regimens concentration time curve should be superimposable. So this is beautiful. We love this. Doesn't happen all the time, but we love that. So this is your CSS max, this is your CSS min, and this is your CSS average. Actually here, this is your CSS min, this is your CSS max, and your CSS average is the average concentration over time. It doesn't mean middle concentration. It means the average concentration over time, which we get by measuring the area under the curve and dividing it by the amount of time between each dose. So the dose interval. I need to move this. Where is this? Yeah, so it looks, so the drug is being given every 8 hours. So the dose interval is every 8 hours. Oops. So our goals, the whole curve needs to be in the range, which with a target CSS average, that average concentration at steady state should be, there should be a targeted number, which in that case was somewhere around 35 milligrams per liter. And what do we control that controls the CSS average? We're going to talk more about that in a minute. But the CSS average is determined by the drug in divided by the drug out. So the drug in, I'm going to try to do this with my mouse. The drug in is the dose rate, how much drug we're giving per time. And if it's given non-IV, we have to consider bioavailability, which is the fraction of drug that's available to the systemic circulation that was originally given. So we'll talk more about this, but it's the bioavailable dose rate over clearance. So the bioavailable dose rate is the drug in divided by the drug out. That's what's going to determine your CSS average. How do I advance? How do I advance? Get out of annotation. And what are our other goal? Our other goal is to make sure that the peaks and troughs are not extreme. So the peak to trough ratio, which is the ratio between the highest concentration you see and the lowest concentration, needs to be within that target range as well. So how do we control that? We control that with dose interval. So if you look back at this, here's our, let me get back to annotation. Here's our peak. And here's our trough. So our highest concentration and our lowest concentration. If we want that to be smaller, we have to give this drug more often. We have to give it more often than every 8 hours. If we want this to be larger, we have to give this drug less often, and therefore we're going to increase the dose interval. Instead of 8 hours, we might go up to 12 or 24 hours, and then we would have a larger. We can't control the slope, but we can control how long we give it between our doses. All right, and I'm going to stop there and let Nick go over the next slide or the next video.